So I think we've all been on these before. Holly, I don't think we've seen you on the last couple, so appreciate you here again.
Thank you.
So there's only a couple things that I had on our roundtable discussion. Then I wanted to see if we can maybe do a couple follow-up items. And then I sort of alluded to it, but I went to a Oracle Health Summit last week, and I thought I could give a couple updates to what I learned or what I heard during that discussion. But first off, I think all of you probably saw a survey come out from us this morning. And really what we do is we have these roundtables, and I think this is probably our most active one, the CNIO roundtable. But we also have a CMIO roundtable, and we're looking at potentially starting up some others as well. So if you could take a look at that survey, or if you don't have it, let me know and we can make sure that you get it. But really, we just want to sort of gauge your interest or potentially others in your organization's interest to join some of these roundtables. Previously, we've done like a PMO roundtable, a registration, or more of a rev cycle roundtable. So if there are others that you're interested in, or you know others in your organization might want to get together and do like a peer meeting like this, certainly let us know and we can maybe investigate being able to pull something like that together. Tamara, did you want to add anything else? I know, thank you for sending that out this morning.
No, thank you. We definitely appreciate your feedback, and hopefully we'll hear from your organizations.
Yep. Thank you. So I put a couple of follow-up items from the last couple of meetings that we had and thought maybe we could see where people are on things. So I think from our last meeting to now, Brant, I believe UTMC went up with your iBus cloud migration. I have April 8th as the date. Do you have any feedback on that? How did that go? Anything that others should be looking out for?
We did not go live yet.
Oh, you didn't? Okay.
Nope, there have been some technical difficulties getting data to show up in PowerChart in the mock domain, as well as our Catman and our CareView board. They switched integration architects midway through our project, so he's playing catch up, and we just couldn't meet our deadline.
Okay. Well, sorry about that. Actually, I was working at a site as well, and we were supposed to go live 2 weeks ago as well with iBus, and everything was working across all the devices except for they had one Massimo device and one specific unit that if it couldn't get a connection to that device, it would send erroneous data through every minute into the chart. So they ended up postponing it. So they are still working both with Massimo and Oracle to try and figure that out. So I don't think, from what I can tell, there hasn't been a lot of people who have moved to the iBus cloud that aren't like a Community Works or an AMS site where they're in sort of a shared environment. So I guess as sites continue to go live, I'm sure others across our little group would appreciate any sort of feedback you can do.
So Brian,
yeah.
Brian, it's Holly. We just did our iBus to the cloud go live actually last week.
Oh, nice. Okay.
But I will say it was probably our most challenging upgrade. So we had, do you mind if I just jump in? Sorry.
Oh, no. Yeah, I love it.
So we did Cerner Millennium and iBus Cloud combined. Originally, we talked about breaking them out, and there's pros and cons to that. But the team felt like they didn't want to go through multiple testing cycles and do a lot of rework, and Cerner recommended putting them together as well. But we ended up having to separate them in the end because we had so many issues with our Alaris pumps. So most of our devices were fine in the lab and other areas. I mean, we had some issues we had to triage through in capacity management, but we ended up having to split out, do our Cerner Millennium upgrade, stay on the traditional iBus, and then push our iBus to the cloud upgrade several weeks later, because we had some connectivity concerns in our non-prod environment with Alaris. And after working with Oracle for multiple weeks, we ended up getting those issues resolved. So, but it was pretty painful, I would say. Looking back, I wish we would have started separating them, because I think we just had too many issues to triage for that big of an upgrade. We're live and it went fine overnight, but I think our biggest issues were with Alaris. So
Those Alaris pumps.
I know.
Continue to
Well, and I
glutton
think
for punishment with those.
I think the challenge was it became one of those, well, it's a BD Alaris issue. No, it's an Oracle issue. No, and trying to find the right resources to get the issues actually worked on and identified was really challenging. So I think once we got those people involved, it was okay. But we did use the upgrade center and didn't have much luck with being able to expedite any of those issues, unfortunately. I think we continue to struggle with support in general and just getting to the right person at Cerner. But anyways, we got through it. We're live now. We're going to be moving some of our lab device. We kept a couple on traditional just because we didn't have the amount of resources to manage overnight with 3 hospitals and all the devices they had to touch. So they're moving the rest of the lab devices over the next several weeks. So.
Okay. Did you use, I think there's like an auto disassociate, reassociate tool. Did you use that, or did you have the staff go and disassociate before the upgrade on the iBus side of things?
I think we did. I can confirm with John, but I think that's part of their standard, but I can send him a quick message when we're on this call.
Oh, I was just curious, yeah, to see how that was. Yeah.
Yeah. The other thing was the heart services that apparently is like a third party that Oracle contracts with for the iBus component.
Mm-hmm.
Just another thing for people to be aware of if you use the upgrade center. If you have to push off your iBus upgrade, it's typically like several weeks to get a reslot date because they're so booked in advance. So that was our other challenge, is negotiating dates, not just with Cerner, but also with the heart services team. So
I've heard of them before. So is that somebody that Oracle is contracting out to, or was that a separate service that you picked up?
It's through Oracle. My understanding is that it's a third party team that they contract with. So when we moved our date, it was not just like, oh, we have to make sure the Oracle resources are available, but the next heart services date is X. So it was a bit of a challenge.
Okay. Yeah, I believe heart services is something similar to like in L-Cave. I think they do some data migration stuff, and I think this sort of falls under what they do. I believe it's a Kansas City-based company there. Interesting. Okay. Hey, Nicole, thanks for joining. Holly was at Concord was giving an update on their Millennium and iBus Cloud migration they just went through.
Oh, awesome.
Yeah, we're happy to, sorry, one more thing, Brett. We're happy to be a resource if anyone has questions, especially if you use the Alaris pumps and run into similar issues. We did find one client that had a similar issue to us prior to go live, and they were able to resolve it. So we were able to work with them as well. But I think it's always challenging to get to clients through Oracle, I find. So using forums like this are a little bit more effective just for like a quick connection point. So if anyone's going through that, one of my analysts was very intimately involved, especially on the IV side. So if anyone has any issues, I'm happy to help.
Well, I appreciate that, Holly, and certainly a big project putting both the Millennium and the iBus Cloud migration there together. Did you do M pages just to round it out?
We did not. I'm trying to think of when we pushed those out. We did a big M page change with our last upgrade, so there wasn't anything specific with this one that we did.
Okay.
We did a Dine Dock upgrade a couple months prior, so that was fun. But and John said we did use that tool, but it didn't work. It didn't work completely, and they had to run a script when some were still associated. So I think it did help some, but it sounds like it didn't get us over the finish line. So Cerner can run scripts for you, but that tool didn't work 100%.
Okay. Appreciate that. All right. I've got a couple other things, but I just wanted to open it up, see if anybody wanted to discuss anything that they are working on or recent upgrades they've done, initiatives that you're doing with your staff, anything like that. I can get us started. One thing that I was thinking about was any sort of surveys that you use with your staff. And one that I was thinking specifically about is like the Class Arch Collaborative that they have. And so they'll come in there, and Holly, you certainly very familiar with this. Come in there, they'll create surveys and then sort of present back the survey results to you on how staff are doing, what they like, what they don't like, areas of struggles and things like that. I'm curious if if you use any services like that, or how you survey your staff and how you use that to sort of drive what you do sort of for your roadmap over the next year.
Hey, this is Andrea. We did use the class survey at Centra, and a lot of kind of what we got back from the class survey is that one of the bigger gaps was really more education. Folks would say, that we need more tools to get the job done, that we should be bringing more technology, but it turned out we already had that, and they just didn't even know that that tool existed. So sometimes, like how the feedback came, it wasn't, you had to sort of interpret it, like, why are they saying this? And so it was kind of funny because they said, no, we don't really need more education. But then they said they needed more tools that we already had that they didn't know we had, which actually meant they needed more education. So it was very good information, but you can't really just take it at the surface. You do have to sort of dig down and then start talking to people like, what did you mean by these numbers? We had meetings where we went back with groups of people and said, here's what the numbers were. What were you, we didn't call out any particular people, but, why do you think these numbers are reflecting like this? And then through those meetings, we were able to kind of deduce, oh, well, you didn't know this was here and that was here. And so we've shifted a lot of this year to how can we get our education to be better, our onboarding process better, and make sure that folks know what tools they have from the very beginning.
Yeah, that's great. Yeah, the education always seems to come up, and I'm sure it's frustrating to look and read survey results and be like, but we have that tool. It's available to you today.
Yeah, yep, that's exactly what happened.
Yeah, we had a similar experience, I would say. The Class Collaborative has a lot of benefits, but I think for the cost, it's an expensive service for, I guess we're a smaller organization, so I'll just speak to, from a financial standpoint for us, and you almost need, I think, a dedicated resource to work with them to really kind of like mine the data, identify opportunities, work with other organizations. I think it's an interesting concept, but I think from a cost perspective, we didn't necessarily see the value. The surveys were helpful, but I think depending on the time of year and what else was going on organizationally, you saw a lot of things come across that I think were how staff were feeling in general organizationally and like the stress of the system versus just on like IT systems, and agree that they would often comment on things that we had, or maybe they just missed an education. So we did utilize it for, you know, tweaking some of our education focus and looking at better approaches to that. But I don't know that you necessarily need that tool to do it. This actually just came up with our new education director. We don't have a common survey tool across the organization to use for other initiatives. A couple people have SurveyMonkey and things like that, but we haven't organizationally had like a standard for that. So it's a good, interesting topic, because I think we used to have class, we don't have it anymore. And now we're kind of in this boat of what do we do now? Because I think the surveys can be beneficial, but we don't really have a standard across the organization.
Yeah, Holly, I certainly understand. And I think maybe when I saw some of the class results, you know, a couple of years ago coming out of there, and I really like that you brought up that I think a lot of times the surveys have bleed over from the rest of the organization. So they'll talk about not having the right nursing ratios, or, you know, pay scale stuff, things that are completely outside of IT, but now it sort of reflects on your surveys, which really is not indicative of the system or things that you have control over. But I don't know how you would ever sort of take that out of the survey or get people to sort of completely focus in on what they need to.
Yeah, I think just speaking on the clinical side, I think it's always going to come out in those.
Yeah.
You know, people have a vehicle to share feedback, they're going to share it. But I do think it speaks to like that the stress of the system is directly tied to how they use the EMR, because there's corners they'll cut if they feel like they don't have enough time to do it and things like that. So, but again, I think survey is important. It's just it's a big expense for, I would say not as much gain as we would have hoped, but I do like the concept of surveying, because I think it's important.
I wonder, you mentioned a common tool. I wonder if you have a common tool for the organization to talk about more general things that are on their mind, that then maybe the IT surveys that you put out would get more IT specific results. I don't know, just sort of thinking about that as well. Like if they have the outlet to provide their results, then maybe they would do that as well.
Yeah, I agree.
Hey, Lori, we are just talking about surveys and how we survey staff, and both Andrea and Holly at Centra and Concord use or have used like the Class Arch Collaborative. So we're kind of talking about that as well right now.
I was just going to echo some things that Holly was saying, that we definitely had bleed over, where it was, you know, you had to kind of, like I said, decipher through the data. Is this because you were upset at the time with how things were clinically and it was being expressed through the EHR, and those type of things when sussing through the data. But one thing that we did find interesting, just as a feedback, when we looked at scribes, our providers that use scribes were the least happy, and the providers who use favorites and did things to customize their view, like work through their M page and customize their M pages and went through all those steps, were the happiest providers. So we found that interesting, because we have lots of providers that are saying we need a scribe, but those are the least happy providers. And it seems, once again, it came down to education. They don't want to touch the system, they don't know how it works, so they want to pump it off to a scribe and tell them to do it. And we just thought that was an interesting finding. Like, well, should we be investing into all of these scribes, or should we, you know, actually go and work with those providers that are asking for scribes and see if like additional education to them would get them to where they need, help them get their favorites, help them get their view where they need to go, dot phrases and all that. Just so that was one of our bigger takeaways from it.
That's really interesting. That's that's a cool thing to sort of go figure out, and then really gives you the data to potentially question that ask.
Mm-hmm. Yep, absolutely.
Anybody else want to talk about sort of how they do surveys or anything that has made you change direction or put things on a roadmap because of that?
So this is Nicole. We've done surveys in the past, but have found, our own organic surveys, but then have seen difficulty trying to follow up on what the team members were really wanting or, asking for and who it was coming from. So we got this huge list of things to fix, but really didn't know what the true root cause was. So what we did a couple years ago was we put informatics nurses, and we worked with Cerner and had some of their team come on site. And we actually shadowed the nurses and were able to see what they were doing and, what tools they maybe weren't using or things that could help in their workflow. Redundant documentation, education opportunities, and put together a whole optimization project around that. And I think I feel like we got better content and next steps actually seeing what they were doing versus things that we've gotten in surveys in the past, because then you're trying to circle back and figure out who submitted this, what were they really talking about. Maybe they used language that wasn't actual terms for things. So that's kind of been my experience, but we have not done the class survey.
Okay. So you've been able to go shadow those nurses, understand how they're doing it, and then create sort of optimizations for the staff, either through tools or training, to improve their usage of the system.
Yeah, and actually through those efforts, we reduced the time in EMR for med-surg nurses by 15 minutes. Which, if you think about it, that's one break, for a team member in their shift. So we saw probably the best optimization results through those efforts.
And then how are you measuring the time? Was that through direct observation, or were you using tools like Lights On?
So we did have a PI project around this, and they did time studies. But we really used our Lights On data to measure that time in EMR. The PI project looked at all of the tasks the nurses were doing. So how many times did they go to the med room? How many times did they have, how long did that take them when the medication wasn't loaded in this med room and they had to go to another Pyxis or med room on the same unit? We were trying to reduce a lot of the burden in those administrative tasks as well. So they did time studies in that space. I don't have any of the information around the whole project as a whole and where they were able to make improvements outside of the EMR space, but I know that was very time consuming on the PI side because they were writing down like to the second of how long it took for a task to be done. But I know, through that we were able to find through those shadowings, where we could make improvements in our supply rooms, where we could load our Pyxis differently. Some of it too, that was during COVID and we had a lot of medication shortages. So there was some things we couldn't do, but we put on a list, and as the medication shortages became more readily available, or the medications became more readily available, we were able to make some Pyxis changes in the way we were loading patients on units that had multiple devices.
So certainly looking at the complete workflow, not just what's in the EHR. That's great. Is that something you're still continuing to do, like the shadowing?
we really focused on med surg nurses, and a lot of that was around, you know, short nursing, staffing shortages. And what we've recently done is looked at our tech workflow and how we can optimize that. So doing some stuff in that space. I think that ongoing efforts are probably needed to continue to look at that and see how we make that more of a routine and proactive exercise versus a reactive exercise.
Okay. Certainly, I know the time commitment to do anything like that is probably pretty significant. So I get how it's probably difficult to fit in.
And I think we just, you know, it really came out of our CNOs asking for, sorry, I'm driving, there's a very loud truck.
I'm sorry.
It really came out of, you know, the need or the request from the CNOs, because they were just hearing that, you know, there was so much burden, a lot of time consuming tasks. They felt like they were spending all their day in the EMR. And when you actually, some of it I think is reality, right? So when you go and look at how much time they're actually spending in the EMR, and we did those time studies and we're able to give back to the CNOs and equip them with talking points around how, you know, you don't have to take your WOW with you every time. You know, we did some of that kind of level setting and showed them the times and the reductions. And I think a lot of it was perception that they were just always in the EMR. Documentation was so burdensome. And I'm not saying, I'm not crediting them, because we made a lot of improvements and strides in that area. But I think those activities are really good to do periodically, because we add and add and add. How often do we step back and take away the things that we don't need to do anymore, or streamline, you know, the additions into the current workflows?
Yeah, that's a great example. You're right. We continue to just put more and more things on, but are there areas where we could actually take the burden off of a nurse? And like that example of, you know, you don't need to be tied probably to your WOW 100% of the time. When can you not drag that into a room and still get the results that you need?
And what we've seen with our tech optimizations that we're doing, you know, we put both Sarah Edge on the phone. We have the ability to document interventions, so all of your ADL pieces. Most of the tech workflow can be done from the mobile device, but then we added single sign-on to our Welsh Allen devices, but we didn't really connect what's the total workflow now that you have all these tools. So you were like, okay, here now you can tap in to sign and send your vital signs to the EMR, and you can use this iPhone to document XYZ. But we didn't sit down and map out what's the process when you go in a room, what are you putting in what device. And I think it wasn't as intuitive maybe to some of the tech, and they were struggling to know, what do I do on the Welsh Allen, what do I do on my phone, how do I get to those screens. So I think we found an opportunity there, you know, to really create that new workflow and then train it back to the staff.
So that's really interesting, Nikki, that when you're bringing that up. So when you guys did the initial testing, was it really just more technical testing, or did you guys include sort of that workflow-based testing?
So I don't think our strategy around that was very strong from the workflow base. We just saw it as a great tool, and this is, you know, putting this in their hands is going to give them the opportunity. And I think we, you know, thinking back on that, we had opportunity to get some techs in and talk through that whole workflow so that they understood how to use it versus, you know, just going live with the new technology.
Right. I see that. I remember seeing that so often, where device oriented or, heavy device implementation, really was always treated like a very technical implementation, and so often, sort of skipped over all of the workflow and integration and handoff components, and handoff between people as well as, different systems and technology components. It was just sort of just plugged in. Um, and I think that there's a huge, I think we're going to be seeing more and more of those types of devices and technologies increasing in our world, and really needing to kind of make sure that there is an established practice of addressing those projects as clinical workflows, and ensuring that those types of um, almost, diagrams of the process are laid out with all those different handoffs, and that specific test scripts are incorporated into the standard practice of implementation going forward. And maybe I just remember that was always a frustration point for me, and it sounds like you guys ran up against that wall with this implementation. Are you changing your standard practices going forward so that you have those types of clinical workflow processes tested?
I wouldn't say that we've officially like talked about that. Going forward, anything new that we implement, I think that needs to be a component of what the education looks like, and reviewing the workflow with the informatics nurses. We're doing a pilot at one of the hospitals, retraining the techs and working with them to make them more efficient.
Mm-hmm.
So hopefully, I'm hoping out of that we have something that we can go system wide and do re-education and training. But it's all the components of the system, right? So like even our nurse call, we have reminders that you can set for 15 minutes or 30 minutes or an hour or 2 hours.
Right.
So how do you work that into your workflow? When do you,
Right.
What kind of task would be appropriate for that? I think we had opportunity there of really explaining what a workflow
Right.
to use
Right.
those tasks and those reminders.
Right. And I
and then
take
incorporate
it.
that into your
Yeah. Sorry, I interrupted you. I take that back like a step further, because I would often, you take your workflow script and you think about all the different workflows, and handoffs and situations that you could use that device or the technology. You outline it in a very detailed testing script, and then use that to write your education, or vice versa. Use your education, but then you need to make sure you've got test scripts that really match that, so you can validate and not just ensure that those processes that for the nurse or the end user, is it works, but also whenever there is an update or a change, we make sure we go back and test those same processes again, because more and more technology, more and more devices are being put in the hands, to improve the care, and I just worry they're not being validated or educated well. So interesting. Thank you.
And I think we do a really good job when there's a big project. So we updated our Cerner tracking boards in the ER to something called ED launch point. So we did all those workflows, right? And then created start, stop, and continues. And then our education reflected, today you do this, tomorrow you're going to do this. These are the steps to do it. And we validated all of that and did testing, around those pieces and the process all the way through. I think where we fall short is when we implement little pieces of technology and don't look at how everything interconnects to each other. So we tested and did the workflows, on the Welsh Allen of doing just vital signs, but we didn't put it together with all the other ADL documentation you have to do and how you use the phone for this and that. The whole workflow of all the technologies and how they complement each other. I think
Yeah.
that's where we could do a better job. You know, I think our processes when we have large projects and you're changing systems out, I think we have solid practices for that.
Yeah, that's kind of what I see as well. So, yeah, definitely. I think there's an opportunity there to have kind of some standard test script processes and education processes. So, yeah. Because, more and more it's going to be the smaller little things. And those are the things that fall through the cracks. And those are the things that take so much time from our care providers when they're not working or divert from their standard workflow.
Nicole, appreciate that. And thanks, Tamara, as well. Anybody else want to talk about surveys or anything?
Brian, I'm just going to add Lori from Covenant.
Yeah, Lori.
One of the things that was really interesting, our last survey, it was, you don't do this like name your hospital. They have Cerner is Cerner, and why don't you do it this way? If anyone has any tips on how to handle that, I would be greatly appreciated. It seems to be a great dissatisfier that not all Fords equal the same Ford, not all Cerners equal the same Cerner or Oracle.
We got similar feedback in our survey too, is that we were like, I've worked at other Cerner sites and I don't know worse. And so that was a little disheartening, but I'm not sure how to address that, but you're not alone.
That is a consolation.
Yeah, I would agree. I mean, we hear that all the time. Like, I worked at this other Cerner place and, my name didn't print with the record. And then we go to Cerner and we're like, hey, this team member is telling us this capability exists. And they're like, no. And so then you go back to the team member and you're like, well, what site were you at? And then you're trying to figure out what they did differently at that site. And you're just kind of chasing your tail. And sometimes it's not even like what the team member thought was happening wasn't the case. So I do feel like we run up against that, that constant comparison between Cerner, other Cerner sites, Epic, why can't Cerner do this? So I don't know if we solve that problem. Let me know.
Certainly the challenge of having an infinitely customizable system there.
Brian, can I ask a question?
Oh yeah, go ahead.
So I'm just wondering, this is Holly, wondering if anyone has transitioned from the D-part discharge process to the DynDoc discharge process. We are currently using the D-part process and have some challenges with duplicate orders and limitations in the way that we can structure, like make it a more patient-friendly option for patients in terms of like the med list and being really clear what's changed, what's new, etc. So we talked to Bay State, they moved to the DynDoc process, but I wasn't sure if anyone else has gone through that transition.
You mean the workflow M page for D-part?
Yeah, so we currently use the workflow M pages, but this would be like moving everybody to a dynamic documentation model. So nursing, respiratory, everyone that contributes to it would have to use DynDoc.
Oh, we have not.
We go live on May 6th with that.
Oh, you do? Okay. How long did
We've had about 8 or 9 units go ahead and start using it beginning of April, when it was coming on May 6th. So we haven't had we had a couple little tweaks, order comments, the nurse's full name printing on there. We've got those fixed. so far so good, and then we're fingers crossed for Monday.
Okay. How long did it take you to work through that project?
I think our analysts started on it last fall, but our ED had already been doing it for the people discharged from the ED. So
Okay.
they've been doing it for a couple of years. We knew it was coming, that we were going to transition away. We go live on Monday with SurgeNet, and so there's no depart button, I'm told, with SurgeNet, so that was our opportunity to make this change.
Okay. Brent, would you mind if I connect with you just to link up two of our analysts, just because I have somebody that's going to be building that out, and she had some additional questions, if you wouldn't mind.
Yes, our analyst, Chelsea, is amazing.
Okay.
She was our Don Doc analyst, so this is, she can definitely help.
Okay, thank you. I didn't realize you could have two discharge processes in the same environment either. So I think we're thinking everybody goes at once, but if you guys, sounds like you guys rolled it out increment, like unit
Well,
at a time.
we ended up turning it on for everyone, but told them they could still use depart.
Okay.
And then we had pilot units come on and transition. And we found we couldn't turn the depart button off. That's going to be on Monday. We thought we would be able to turn it off as each pilot unit progressed, so that they didn't have a choice anymore, but found out we couldn't do that.
Okay. All right, thank you.
But yeah, reach out. We'll get connected.
Okay, perfect.
Hey, Holly, this is Andrea. Not at my current organization, we still use depart, but at my previous organization, we did make that flip, and we did it all at the same time. And we actually had different workflow M pages for discharge based on certain service lines. So we try to keep it as high level as possible, but we had like an ED one and then an adult and a pediatric, because there was just some things that you would want to have on that summary that differed from one to the other. So we ended up developing multiple discharge workflow M pages and having it, but all living in the single viewpoint. So it worked in the end, but it was a high education point to say, make sure you're on the correct workflow M page when you're doing the discharge based on what patient you have, if you're Peds or adult or ED. But it was a big effort system-wide because it was a big education workflow change, and it took a lot of testing to make sure that everything came out correctly.
And do you feel, I guess the question, do you feel the output is that much better? Like, I guess was the project worth the gain you got?
I think so.
Okay.
I definitely think it was better afterwards. It was better, especially around medications, like where they could fill in when they had their last one. So basically the workflow was that you should really not generate that discharge workflow Dine Doc note until the very, very end, because then it would pull in where they were in their medication schedule, and it would be fairly accurate. And that was a big changer, because before that it was just sort of a manual process that we had going on.
Yeah. Okay. All right. Thank you.
Mm-hmm.
Thanks, Holly, for bringing that up. Any other questions that people wanted to throw out to the group?
I have one.
Sure.
It's just more, it's like this repeating thing that keeps coming up, and it's around obtaining a patient's signature, not related to registration and scheduling, but like in the middle of their care, like with behavioral health treatment plans, or, our MRI folks say that, in our screening form, the patient should be signing in there. And we just don't have a very good way to go about signatures. And I'm not sure even what are the possibilities around patient signatures and obtaining them for those type of middle of care workflows in the inpatient setting. We're struggling to make it happen.
Okay.
Just, do we print off the power form, have them sign it, scan it back in? Is that our only option? Are there other solutions out there?
I will, again, Lori from Covenant, I will confess, we ended up building our own internal process, and it's basically a web page that pulls the power form. We use, you can use an iPad, but we use our TC 51s or 52s or whatever they are these days, and have the patient sign on that. And then that gets imported, basically cold fed back into the chart. So we could not find, well, let me say, we probably could have found it, but could not afford the other options.
Okay.
Nicholas didn't join today, but Nicholas has a solution for it. I'm going to see if I can find the name of it for you.
That would be great. Thank you.
All right, we've got about 10 minutes left. I was going to give an update on the Oracle Health Summit that happened last week, unless anybody has anything else they wanted to bring up this week. So Lori, feel free to jump in as well. I know you were there also. So just for context, last week, Oracle hosted what they call their Oracle Health Summit in Nashville. It was a one-day event. I guess there's probably, I would say 250 or 300 people there, but really just a number of different sessions that were just all together in a single room, primarily led by Oracle executives, plus some CIOs from some of the larger health systems across the country. But really a couple of things they really focused in on were really their kind of dedication to what they're doing from an AI perspective. And let me just preface this by saying this is what they're saying. I'm relaying the information, whether this happens or not, to be seen. But really, they really talked a lot about the clinical digital assistant, which is, I would say, their answer to Nuance's ambient care piece that they have out, which is basically it's an AI system that's listening to what the clinician is doing throughout the day through and helps them sort of automatically create a note. It does dictation. It does what they call action assistance. So it can help sort of place those orders directly without having to go touch a keyboard. So they're really touting that as a big time saver from a provider perspective. I didn't really hear a whole lot of how that's going to trickle down to some of the other clinicians and nurses in a hospital, but that's in a pilot right now. And so they've got a couple sites that are up and using it, providing feedback, but I know they're certainly looking for more organizations to help with that. So that was one of the big things they talked about. They talked a lot about their OCI cloud infrastructure and moving to that, really touting that as a more secure place to store data. Really kind of focused in on some of the ransomware attacks and making sure that they are securing the clinical data that's out there. And then they did talk about some new advancements they're doing in patient portal, what they're calling patient administration, which is the reg sketch and patient self-scheduling, and then the payment structure as well. So really, I guess more of what would be on the Revelate side of things or the financial side of things, and really kind of cleaning up that, which I think has always been one of the weak points of what they've done. I've not seen that anywhere, but I do hear that it's at least hitting the minimums of what needs to be done, which I think sometimes RegSketch and some of those tools couldn't even do that. And then Larry Ellison was there. He talked for about an hour. Really focused in on the data that's being put into the system and how they use that to create better outcomes. And they kept coming back to clinical trials and saying when a clinical trial is over, you don't really collect the data anymore. And so he wants to be able to use that data to continue to refine and med treatments and how medications are used to improve patient outcomes. And I think certainly a big picture thinking of really wanting to solve everything. And that was kind of his words. He wants to solve everything and that's wrong with care right now. So it seemed like a lot to bite off, but it had more the big picture vision that maybe has been missing the last few years out of Cerner or Oracle. Lori, I'd love your thoughts. I know you're there with the team, and I'm sure Covenant talked about it as well. How did you guys think, or anything that I missed there?
No, you covered the big pieces. The one that we have talked a lot about, and obviously it hit Becker's this week, is, let's solve all the problems. I believe was Larry's. Let's take on Elon Musk's theory and just solve all the problems. And I think I come back excited about that, but also as we're going through an upgrade, I'm like, yeah, but can you fix this one first?
Yeah.
was kind of the thoughts that I came back with. I think I also heard very, very loud and clear that they are, and I think their CMO has a lot to, their chief medical officer has a lot to do with that. They are really trying to relieve a lot of burden of documentation. And it's just going to be, my other hat is quality. It's going to be interesting to see how they do that and not affect discrete data required in today's quality world.
Yeah, I kind of had a note as well about staff burnout, and I think that absolutely goes into sort of the documentation reduction that they're talking about. But I don't know if that's at odds with the using the data in order to be able to sort of drive some of these outcomes that he wants as well. Right. Yeah, I think I took my note. Lori, it says, Larry's quote was, "We can do it all." So they want to clean up how providers work, how payers work, the supply chain, the hospitals, clinical trials. But yeah, it's kind of like, well, I would just like to be able to to get my issue resolved and have a resource I can contact when I have an SR that I've logged first. But I'll say, I think overall, it made me feel like there was direction on where they're going. And I don't know how everybody else feels, but it felt like for a while, there was no sort of roadmap on where Oracle is taking things. And now it feels like maybe it's getting a little more clear on things. So, I'm not an apologist, but I certainly think that they're trying to make some inroads on things now. All right.
Brian, I missed who was asking about the e-sig for clinical forms, but I did reach out to Nicholas, and the thing that they're using, the application is called Interlace. And so I put the information in the chat, but the app manager or the director of that application said he doesn't really love it. So I'm asking him what specifically he doesn't like, but hopefully that's helpful.
Thank you. Yes, that's we appreciate that.
But at least you could look out and see who their major competitors are, right?
Right. Yeah, that's a starting point for sure.
Yeah, and if he replies back on what specifically he doesn't like, I'll put that in the chat as well.
Thank you so much. Yeah, because we're kind of right in the very beginnings of this. It's just, we know it's a problem, we got to address it. But where do we go from here?
Yep.
Great. Thanks for tracking that down, Patty.
Yep.
All right. I think I was just looking ahead to our next meeting. I think it's sitting right now on July 3rd, which I know I will be out, and I imagine most of you will be. So I'm going to go ahead and get that moved out to July 10th. I know we're starting to really hit some of the holidays and getting into the summer there. So if you feel like that doesn't work, we can always cancel that one in July and pick it up in a couple months later. But for now, we will keep that out there on our agenda. Appreciate it again, as always, everybody jumping in. I think we covered a lot today. So I really think these are helpful. So I'll get some notes together here and get that sent out and posted as well out to our website. So thank you, everybody, and have a good rest of the day and week.
Thank you.
Bye.
Thank you.
Thanks, guys.
Thank you.